So welcome back, my dear doctors. So this is about endocrine physiology, but most of the questions are coming from the receptor physiology. So there are two types of receptor. One is cell membrane receptor, other are nuclear receptor. So cell membrane receptors are the receptors which are basically on the cell membrane. For example, G protein couple receptor, number one, G protein couple receptor, in which there are three: G stimulatory, GS, G inhibitory, GI, and third is GQ. Third is GQ. G stimulatory is secondary messenger is cyclic AMP, but this is going to increase cyclic AMP. This is going to increase cyclic AMP and phosphorylate whom? Protein kinase A. Protein kinase A phosphorylation. Phosphorylation. G inhibitory. Secondary messenger is again cyclic AMP, but here it is decreasing cyclic AMP. So again protein kinase A will be dephosphorylated. Dephosphorylated. GQ. GQ secondary messenger is IP3 DAG, inositol triphosphate diacylglycerol, and secondary messenger is calcium. So mostly GQ will be there whenever you need to contract something or constrict something. So number one, cell membrane receptor will be G protein couple receptor. Clear? Second is receptor tyrosine kinase. Receptor tyrosine kinase. Third is tyrosine kinase associated receptor, also called as JAK-STAT. Janus kinase. So basically, there are three types of cell membrane receptor, although there are serine kinase, but at least you must remember these three types: GS, GI, GQ, and also you must remember the examples. The most important question will be your examples. Please do remember for your exam, definitely 3-4 questions will be only from example of GPCR. G stimulatory, increasing cyclic AMP. The number one example is glucagon, then ACTH, then TSH, LH, FSH. Parath hormone also work on G stimulatory hormone. Then vasopressin. Now ADH has three receptor V1, V2 and V3. V2 receptor act on GS. V1 and V3 will act on GQ. I will discuss later on. Calcitonin, human chorionic gonadotropin SCG. Then dopamine via D1 receptor. Again, there are D1 and D2. D2 is GI. I will tell you later. So these all act on G protein couple receptor. These all will increase cyclic AMP and ultimately they will phosphorylate whom? Protein kinase A. Same mechanism. Now GI, G inhibitory. Okay. Number one example is somatostatin. Somatostatin is also called as universal inhibitory hormone. Dopamine via D2 receptor. D1 receptor was GS. Epinephrine or norepinephrine via alpha 2 receptor, because alpha 1 is GQ. I will tell you later on. Alpha 1 is GQ, alpha 2 is GI. Okay. Angiotensin 2 in certain tissue. Acetylcholine via muscarinic 2 receptor only. There are muscarinic M1, M3, M5. So M2 and M4, these are GI, and M1, M3 and M5 are GQ. They are GQ. I will show you here in the GQ. Examples are angiotensin 2 via angiotensin 81 receptor. Angiotensin 2 are having two receptor, 81 and 82. 81 is GQ. Okay. Epinephrine or non-epinephrine via alpha 1. Alpha 1 is GQ, alpha 2 is GI. Now see, M1, M3, M5, muscarinic, acetylcholine, again GQ. Vasopressin ADH via V1 and V3 receptor, both are working on GQ. Thyrotropin releasing hormone, gonadotropin releasing hormone. So almost all releasing hormone work on GQ except CRH, which is GS. All releasing hormone gonadotropin releasing hormone, growth hormone releasing hormone, thyrotropin releasing hormone, they work on GQ except CRH, corticotropin releasing hormone, which is GS. Then oxytocin, then histamine via H1 receptor, and then prostaglandins via EP1 and FP receptor. So GS, GI, GQ, this was about G protein receptor. The fourth, guanyl cyclase cyclic GMP system. GTP is converted into cyclic GMP via guanyl cyclase. Now, cyclic GMP is secondary messenger. Like there was cyclic GMP, here will be cyclic GMP, and this GMP will be inactivated into simple GMP by phosphodiesterase. So, cyclic GMP is a very important secondary messenger, act via secondary messenger, and they act as a vasodilator. And the ligands which is going to activate this guanyl cyclase activator is called as ANP and nitric oxide. This was all about G protein receptor and guanyl cyclase activator. Now receptor tyrosine kinase. Examples, very easy. Insulin, very easy to remember. Insulin plus all growth factor except TGF beta. TGF beta is serine kinase. Serine, not tyrosine kinase. So whenever at the end you have growth factor like nerve growth factor, like endothelial growth factor, platelet derived growth factor. So whenever you have growth factor, most of the time receptors are tyrosine kinase except TGF beta, which act on serine kinase. Now you will not forget. That is why tyrosine kinase blocker like imatinib mesylate, or dasatinib mesylate, they are given in CML or GIST in tumors, because if you block the receptor, growth factors will not act. Okay. Now tyrosine kinase associated receptor or JAK-STAT. JAK is Janus kinase and STAT is signal transducer and activator of transcription. They will activate transcription. It is called as JAK-STAT. Okay, cytokines act on these receptor. Cytokines like interleukins act on this receptor. But if you want to remember, very simple mnemonic: growth hormone plus so many statin, like so many tin, like leptin, prolactin, like erythropoietin, leptin, okay, thrombopoietin. Okay, so these are acting on JAK-STAT pathway or tyrosine kinase pathway. Growth hormone, not growth factor. Growth factor was acting where? They were acting on tyrosine kinase. This is tyrosine kinase associated receptor. Steroid hormones have receptor in the cytoplasm or inside the nucleus because they have genomic activation which is very, very slow. They are of two types. Nuclear receptors are of two types. Type 1 will have receptor in the cytoplasm, and if cytoplasmic receptors are free, they will enter inside the nucleus and activate the gene. So you cannot rely on them because they will activate the genes without any ligand. So these cytoplasmic receptors are always busy with heat shock proteins or chaperone protein like HSP90, so that they should not get activated without any ligand or hormone. So when ligand come, okay, so they attack HSP90 because heat shock proteins should not go into nucleus to activate them. So if there is no ligand, they should not go in the nucleus to activate the genes. Only when hormones come, only when ligand comes, Okay, only then cytoplasmic receptor run for hormone receptor complex, and they will enter the nucleus to cause genomic activation, which is always slow. Genomic activation is slow. Type 2 receptor is at the level of nucleus. Nucleus receptor attached to DNA. That is why there should not be any undue activation. So they should be suppressed by co-repressor proteins. Only when hormone get attached, they should activate nuclear receptor. Now, cytoplasmic receptor form homodimer. Cytoplasmic receptor form homodimer, and nuclear receptor form heterodimer. Heterodimer with whom? With RXR. RXR. So nuclear receptor will form heterodimer with RXR. So heterodimer ligand when attached to nuclear receptor, and also it will attach to RXR, and this is called as heterodimer. Then it will remove co-repressor protein and genomic action will happen. So now onward, always remember there are homodimers, there are heterodimers. Homodimers receptor will be in the cytoplasm, and the examples are estrogen, aldosterone, progesterone, glucocorticoid. But heterodimers receptors will be in the nucleus, and they are thyroid hormone, retinoic acid receptor, vitamin D receptor, PPAR alpha and gamma. So thyroid, retinoic acid, vitamin D, PPAR alpha and gamma. In the pharma, they will discuss alpha agonist fibrates, gamma agonist pioglitazone, alpha gamma dual agonist. Do you know? Saroglitazone. Okay, so this is about the pharma. Now hypothalamus. Hypothalamus, okay, normally it is regulating anterior pituitary, and posterior pituitary cannot form any hormone but release hormone which are formed in the hypothalamus. So hypothalamus control anterior pituitary, like CRH, corticotropin releasing hormone. It is GS, you know that. Will activate whom? ACTH. CRH in the hypothalamus will activate whom? ACTH. GnRH, gonadotropin releasing hormone, will activate FSH and LH. Is this clear? Now, thyrotropin releasing hormone will activate TSH. Clear? Now, GHRH, growth hormone releasing hormone, will activate growth hormone, and dopamine will inhibit prolactin. The only inhibitory hormone, dopamine, will inhibit prolactin, and you can see TRH also activate prolactin. That is why hypothyroidism. In hypothyroidism, when there is more TSH, more TRH, prolactin will be more and causes amenorrhea. So menstrual disturbance in hypothyroid is because of this increased prolactin. Now somatostatin is also inhibitory hormone. It can inhibit growth hormone also and can inhibit TSH also. Clear? And dopamine can also inhibit TSH. Like that, you can see this is a wonderful diagram. Growth hormone and prolactins are released from acidophilic cell of the pituitary gland. Rest all are released from the basophilic of the pituitary gland. This single diagram will solve all the MCQ related to the hormones from hypothalamus and pituitary. Is this clear? Now, growth hormone. Growth hormone, the most abundant hormone of anterior pituitary. Most abundant hormone of the anterior pituitary is called as growth hormone. Growth hormone and prolactins are from acidophilic cell. Now, growth hormone, some action are direct. Some action which growth hormone act is called as direct. Some action are done by IGF, which is released by liver under the influence of growth hormone. These actions are called as indirect. Some actions are called as direct, which are done by growth hormone. Some actions are called as indirect, done by IGF. Direct action and indirect, some are same. For example, protein synthesis, epiphyseal growth, both are same. So action of growth hormone and IGF is also called as somatomedin. somatomedin are same like protein synthesis and epiphyseal growth. Rest are opposite like lipolysis. Growth hormone causes lipolysis. IGF causes anti-lipolysis. Growth hormone is diabetogenic hormone. It increases insulin resistance or decreases insulin sensitivity. On the other hand, IGF is anti-diabetic, like insulin-like activity. One action is different from IGF, sodium retention. So by this flow chart, you can understand all the function of growth hormone and IGF. Now, growth hormone is lipolytic. That is a good thing. It will increase protein synthesis and dissolve the fat. So what are the stimulus that increases secretion of the growth hormone? Hypoglycemia, exercise, fasting, protein meal, infusion of the arginine, glucagon, going to sleep, we sleep, NREM, stressful stimulation, even psychological stress, pyrogen. So please do remember these are the factors which are increasing growth hormone. Now stimulus that will decrease the secretion. Those were the stimulus that will increase growth hormone. Hypoglycemia, fasting, exercise, NREM sleep. Now it is decreased by REM sleep, glucose, cortisol, FFA, free fatty acid, medroxyprogesterone, growth hormone, and IGF via negative feedback mechanism. Now the prolactin causes increase in the size of the breast. Mammogenesis, it causes what? It inhibits ovulation. Okay. So what are the factors that increases prolactin? It is maximum during pregnancy, lactation, suckling, REM sleep, stress, exercise, hypoglycemia, dopamine antagonist, and sexual intercourse. It is decreased by dopamine agonist like bromocriptine. Now, what are the actions? Lactogenesis stimulates milk production. Increase size of the breast, mammogenesis. Decrease ovulation, decreases spermatogenesis, and decreases sex drive or libido. Now, thyroid. To understand thyroid, you need to draw one simple diagram of the follicle. This is the follicle. This is the side of the lumen. This is the blood vessel side. Okay. Now, sodium iodide symporter on the basolateral side, secondary active transporter. Then pendrin will throw this iodide in the lumen. This is called as pendrin. Mutation of the pendrin causes pendred syndrome. You know that in ENT. Now iodide will be oxidized, oxidation into iodine. Number one reaction, oxidation of iodide into iodine. Now second is that inside the thyroid follicle we have thyroglobulin. So now there will be organification of thyroglobulin. What is that? The second reaction will be organification. So iodide will attach like this, either single or double. Now it can convert into monoiodotyrosine and diiodotyrosine, MIT and DIT. Organification. Third is called as coupling. If DIT combines with DIT, it forms T4. If MIT is early in the chain, DIT late in the chain, it forms T3. If DIT is early in the chain, MIT is late in the chain, it forms reverse T3. And all these will get endocytosed into the blood. In the blood, we will have T3, we will have reverse T3, and we will have T4. Clear? Now, T4 is called as precursor hormone or simply pre-hormone. It is called as precursor hormone or pre-hormone. It can be converted into either T3 or reverse T3 or both. By which enzyme? T by deiodinase. Deiodinase. It is D1, it is D2, it is D3. Clear? So this is clear. So please do remember these two diagrams are very important. And the last point. First reaction is called as oxidation. Second is called as organification. Third is called as coupling. All these three are acted by which enzyme? TPO, thyroid peroxidase enzyme. That is why we see anti-TPO antibodies in a lot of conditions. So it is called as TPO. In anti-thyroid drug, they are TPO blocker like methimazole, carbimazole, propylthiouracil. I hope this is clear. This much is clear. Now, sodium iodide symporter is also present beside thyroid into the salivary gland, gastric mucosa, placenta or choroid plexus. Now coming to the plasma protein binding. Plasma protein binding, see, either they ask you about T3 or T4. Maximum binding of the T3 and T4 is with whom? Thyroid. It is by thyroid binding globulin. It is by thyroid binding globulin. So maximum T3 and T4 bind with thyroid binding globulin. Whatever T3 is left will bind with albumin. And whatever T4 is left, it will bind with prealbumin. Prealbumin, which is also called as transthyretin. Which is also called as transthyretin. Clear? Now the function of thyroid hormone on the heart. It has chronotropic effect and inotropic. What is chronotropic? Increases heart rate. What is inotropic? Increases force of contraction. It how? By increasing number of beta adrenergic receptors. It enhances response of circulating catecholamines, and it also increases proportion of alpha myosin heavy chain with higher ATPase activity, and this can cause more force of contraction. Adipose tissue, catabolic, it stimulates lipolysis. Muscle also catabolic, increase protein breakdown. Bone promotes normal growth and skeletal development. Nervous system promote normal brain development. Gut, increase rate of carbohydrate absorption. And lipoprotein, it forms LDL receptor. Other, it stimulates oxygen consumption by metabolically active tissue. How? By activating sodium potassium pump. But what are the exception? Testis, uterus, lymph node, spleen, anterior pituitary. Except these. Clear?